Live on YouTube.
We are now live on YouTube. I'm starting the recording. So, welcome you all. This is Ranjit Sahu, Marketing Head with Walter Buston. Welcome you to this lovely webinar. Kanpur Menopause Society invites you to this live webinar on a very important topic, that is menopause hormone therapy, that is MHT. We have our esteemed delegates across the country who have joined for this important webinar. So with this, I want to call upon Dr. Garima Gupta. She is Assistant Professor, GSPM Medical College, MSDNB. She is the Secretary, Kanpur Menopause Society. She has good clinical practices course from NDA Clinical Trial Works. She has done a lot of works when you talk about in critical care support from SCCM, that is Society of Critical Care Medicine.
Mr. Ranjit, thank you so much. Thank you for the kind
With this, ma'am, I hand over the session to Garima ma'am to take it.
Please share the CVs. Yeah. Namaskar. A very good evening to all our respected faculty members and delegates. Today we are gathered here to discuss a very important and pertinent topic, that is your hormone therapy. Oprah Winfrey had said the next generation of women is going to take control, take control of their health in a way our generation is only just now figuring out. This is very true since the advent and practice of using MHT in a large population of patients. With this in mind, now I request our respected President, Kanpur Menopause Society, Dr. Kiran Pandey ma'am, who needs no introduction, to give her welcome address. Over to you, ma'am.
Thank you. Thank you, Garima. Good evening, all the respected, legendary and esteemed guests. President Dr. Shobna Mohandas, General Secretary Dr. Anju Soni, Dr. Ambuja, Dr. Sudha, Dr. Jignesh, and many more, all of them who are joined here in this webinar. As you all know, the Kanpur Menopause Society is still in its infancy. But since we have established it into the Silver Jubilee year, when the Dr. Jignesh was a
hyperactive infant.
Yeah, yes. So that is what I was going to say. We have been quite active. We have done many webinars. We have tried to do public awareness programs and even camps and other things. And in this series only, we are now doing this menopause hormone therapy webinar. I would like to just say 2 lines here, that though, as Dr. Shobna was saying few minutes back, that it is many a times menopause therapy has been talked about. But ma'am, as we all know, this hormone therapy, just because of one study, WHI study, I mean, the things which it was being used so widely all over, though not, I would say, very judiciously every time, but with one study, it has taken so much back that in spite of you will be talking for 100 times throughout your presidentship, still the people have to learn and to take the courage to use it. So that is why it is very important. I actually heard your webinar into the Agra and I was very impressed, and I wanted that the Kanpur people and other people should also be benefited by it. So that was with this aim we planned this. I welcome our guests, Dr. Ambuja and Dr. Jignesh, under which their leadership I have worked as a president. Dr. Meera Newtri, our chief patron, could not join because of a family function. And I welcome Dr. Shobna again and Dr. Anju Soni. They are our esteemed speakers who will be telling you the nitty-gritties of the menopause, hormone therapy, how to use it, when to use it, and they'll try really. I mean, it's very important to understand the judicious use, and that is the core of this part. I welcome the chairpersons, Dr. Aarti, and Dr. Kiran Sinha, Dr. Uh, Dr. Pragya joined. I don't know from Garima, just see she has joined or
Yes,
not.
ma'am. Abhi nahi join kiya. I'm just calling her up.
It's okay. Dr. Kanchan is there. Dr. Pushpa also. Dr. Shudha has joined very nicely, and we do have lots of panelists and the other persons, our organizing committee and everyone. So I welcome everyone. Not taking much time. I just wanted to basically. My aim is that I wanted everyone should learn more and more about the MHT because it really needs, in my opinion, because many a times when the patient comes, it needs, but everyone is hesitant. So that is the important thing. The efforts could only be done because of my diligent secretary, Dr. Garima and Dr. Divya, who have been working on this. I have not contributed at all into this webinar, except that telling them, please arrange, please arrange, please arrange, because I am busy with my, I have to go to US in 2 days. So little bit hurry up things are there. So thank you, Garima. Thank you, Divya, and all my organizers who have joined here. Dr. Usha Goenka, I just noticed she has joined, President of Kanpur Obsgynae Society. So all of you are welcome. And Dr. Garima, please carry forward. Let's start with this introduction. Welcome by the other guests.
Thank you so much, ma'am. Now I humbly request Mr. Vishal, please display the DVO of Ambuja, ma'am.
पहले तो
ma'am needs no introduction. I know ma'am, you don't need any introduction, ma'am. Just
no, Garima. First you call
sir. Yes, ma'am. Jignesh sir. Yes, sir.
Yeah.
Sorry, ma'am. Ma'am, actually, उन्होंने photos गलत लगा दी तो उसी sequence में लगा हुआ.
No problem. No, we'll correct you. Don't worry.
Thank you so much, ma'am. Sorry, sir. Sir, now I humbly request Dr. Jignesh Shah, sir, who needs no introduction. Sir is a very humble and assiduous personality, I would say, a visionary. He was past president, Indian Menopause Society, vice president, Indian Society of Parentology and Reproductive Gynecology. And in his tenureship, we have started the Kanpur Menopause Society under his guidance. We welcome you, sir. Please give your blessings.
So thank you, Garima, for kind introduction and also for today's invite. I congratulate Kanpur Menopause Society for organizing this webinar on very important topic, menopause hormone therapy. The Kanpur Menopause Society was installed in the year 2020, which was a landmark year for Indian Menopause Society, a silver jubilee year. And Kiranji was the founder president and Dr. Meeraji was the chief patron for it. I think, Garima, you were the secretary at that time, no?
Yes, sir. Yes, sir. It was
and
the first webinar.
Is doing very good.
Thank you
so much. Congratulations.
Thank you. Kiran ma'am said your guidance, sir.
In the silver jubilee year, we also published the revised guidelines regarding menopause hormone therapy to practice menopause in India, and which was very well circulated to all our members. And we have kept number of seminars regarding these revised guidelines, not seminars, but webinars. But still, even today, there are many points needs to be cleared, especially the confusion arising in special clinical situations and especially in comorbid situations. So here, the speakers are not other than our president itself, Dr. Shobhana, and Secretary Dr. Anju Soni, and both are very dynamic, very energetic, and very learned. So I'm sure they will throw the light on all the prevailing confusions regarding the use of menopause hormone therapy. And we have the panel of experts like Dr. Pushpa Shetty and Dr. Sudha Sharma with a battery of very learned chairpersons. So I am sure today's webinar will help all the practicing menopause specialists to clear their confusions and to implement in their clinical practice. And my namaskar to my buddy Didi, Ambuja Madam, namaskar. And thank you again to Kanpur Menopause Society. Thanks for making part of this webinar. My best wishes to today's webinar.
Thank you, Dr. Jignesh.
Thank you so much, sir. And so Shobna ma'am too was there when the Kanpur Menopause Society ma'am, when we were when inauguration was done, ma'am, you were also there as a GCM member. I think Vice President was there. So
And Dr. Ambuja was also there in
Yes,
that first program. Dr. Ambuja was there. She
Yes,
talked
ma'am.
about the urogenital.
yes,
Yeah.
I remember.
ma'am had a talk, yes, ma'am. Now I humbly request our innovative and inspiring Dr. Ambuja ma'am. Mr. Vishal, please display ma'am's CV. Yes. Ma'am, with the past president in Menopause Society, and under her tenureship, we have seen many new programs like the CIMP, the FIMS, which has taken place. We request you, ma'am, we welcome you and request you to give your blessings, ma'am.
Thank you, Garima.
Yes,
Ma'am, I want to say one line before that. Dr. Ambuja, when we used to look you at as president onto the screens, I somehow had the impression that you must be a strict person or something. But when I met you in the conferences, you were very vibrant and bubbly, like the same being. Photo khichani hai, center wear.
And ma'am,
Thank
you're
you.
so beautiful, ma'am, with a shiny skin. I was just started to see, ma'am.
So I love that interaction with you and taking photos with you.
Can you please excuse me for 1 second? I am coming back.
See.
Ma'am, Pragya ma'am has joined. Welcome, Pragya ma'am.
Okay, welcome, Dr. Pragya. I have not been able to see. Maybe.
Ma'am, gallery mode में कर लीजिए.
Gallery mode में, हाँ. Okay.
कोई डोरबेल रिंग हो गया होगा अंबुजा मैडम.
Yeah, हो जाता है.
Thank you for all the kind words. My day is done today. I'm going to celebrate a lot. And thank you for all the introduction, Garima, and Dr. Kiran, Dr. Shobana, and Dr. Jignesh. And I don't know how to express thanks for inviting me and making me a part of this program. And good evening to all the chairpersons and all the dignitaries that are present. Anju, my beautiful Secretary General, where is my Sudha? Yeah, Sudha the Great, always. For everybody, good evening. The subject today is really, really wonderful subject. Even if we hear for 100 times, we get something new in that one, some point somewhere. And especially it is the NAMS, that is a North American Menopause Society, has released just about 6 days back the new guidelines, that is the revised guidelines in 2022, where Indian Menopause Society endorsement also is there for that one. Of course, all of us know about that. That is the extended use of the MHT. I don't know how much to say. As Shobana said, we are listening, talking, but still how much we are following. That is the main thing.
Madam. I missed out on the NAMS.
It's okay, no problem. This is only 2 words. Now, what I mean to say is, we are listening, talking, but still, how many of us are really advocating for everybody? How many people are following? That's the main thing. As Kiran said, once the दूध spoil हो गया, वो फिर नहीं हो पा रहा है. Because the WHO study which gave with some statement, nobody is able to still correct that one. And what about the norms telling extended use after 60 years with the mutual consent from the doctor and from the patient. We can use the hormone therapy after 60 years and only for the continued vasomotor symptoms if they have. And they endorsed the statement and given the green flag for the use of vaginal DHEA and then ospemifene. Until now, ospemifene was in the 4th stage. And now it has given a green signal that it can be used for the GUS, that is the genitourinary syndrome. These two things it has endorsed, and it's only just 6 days back it has come. So again and again, we have to learn and learn every day something new or other. And I'm happy the learned person, Shobana, is speaking
No,
about
I have
that
to
subject.
change my slides now. No time.
And Anju is going to add on to that one. And we are going to really revise our subject. And thanks to everybody for giving
pardon me for writing 55 years. I did not update myself today.
No problem, sir. Shobna, see, all of us, why we are here, we help to each other. That's what is the webinar. If somebody is telling something, yes, I will note down. When you are talking and I'm talking, somebody will note down. So that's what is the thing that is happening. And hats off to Dr. Jignesh Bhai. Because of you, it happened, which was impossible. You made it possible to meet so many people. Otherwise, we would not have remembered so many people coming like this and talking. And you are the king of the webinars you started. And really, really, we are appreciating. Now we are more getting familiar with the webinars than meeting physically. Really, this is good also. Once in a way, of course, we'll have the physical meetings. Otherwise, this is really good. Everybody is liking also. Is it true or not? Everybody is liking. Sitting at home and meeting so many people and hearing so many good things. Yeah, this is really good. And finally, namaste to all of you and thanks for giving me the opportunity. Thank you very much.
Thanks, ma'am.
Thank you so much, ma'am. Mr. Vishal, please display the CV. Mr. Vishal? Yes, thank you so much. So for next session, I would like to invite Dr. Divya Tripathi, who is working as Assistant Professor in GSM Medical College. She is Joint Treasurer, Kanpur Menopause Society, a very diligent and hard worker. Over to you, Divya.
Hello, Divya.
Divya, unmute kariye. She is there. Unmute.
Thank you, Dr. Garma. Dr. Vishal, display the next CV. Good evening, all dignitaries present here, and I welcome you all. Now heading towards our next academic session, which is about the hormone menopause hormone therapy. I would like to introduce the chairperson for the session, Dr. Aarti Gupta. Dr. Aarti Gupta, ma'am, is President-elect IMS. She is very compassionate and thoughtful and loving person. Besides contributing to the field of gynae ops and menopause, she is also working for the social service in the form of Saath Saath Society. Okay. She is recipient of many awards. I welcome you, Aarti ma'am.
Thank you, Divya. Thank you so much.
Our next chairperson is Dr. Kiran Sinha ma'am. Ma'am is Secretary of ISOPAP Kanpur Society and she is Senior Secretary of Cox Kanpur Ops and Gynae Society. She has been working in the government sector for the last 4 decades. Ma'am is very systematic and motherly figure and she is very impartial in her nature. I welcome you, ma'am.
Thank you, Doctor.
Now I request Dr. Aarti Gupta ma'am to introduce our expert, Dr. Pushpa. I think Pushpa Sethi madam is not here.
Yes.
Dr. Sudha ma'am will be taking the session as expert. Kindly display the slide of Dr. Sudha Sharma ma'am. Dr. Sudha Sharma. Now I request Dr. Aarti ma'am to introduce our expert, Dr. Sudha Sharma ma'am.
वेलकम सुधा जी, आपको इनवाइट करना और आपको वेलकम करना इज माय प्राउड प्रिविलेज एंड ऑल ऑफ अस नो she has been Secretary General of IMS in 2021 and 22. She is honorary professor of IMA, managing committee member of PCO Society of India. Thank you Sudhaji, thank you so much. You are a very loving personality and I love you.
Thank you so
Thank
much.
you
Thank you for the kind words.
Thank you, ma'am. Now I request Kiran Sinha ma'am to introduce our today's speaker, Dr. Shobna Mohandas ma'am.
Thank you, Dr. Divya. I am feeling really honored to introduce Dr. Shobna Mohandas, madam. She is at present holding the post of President Indian Menopause Society. She is Chief Consultant Gynecologist and Laparoscopic Surgeon at Sun Medical Center, Thrissur, Kerala. She has graced many chairs as Vice President IMA Thrissur, Mission Pink Health IMA Thrissur. She has also member of past president of FOXI Food and Drug Committee and Endocrinology Committee. She has authored 2 books in gynecology and also contributed chapters in several textbooks. Madam is a very, very good orator. I always, when I see the flyer of Menopause Society, I just point out who is speaking, whether it is Dr. Ambuja or Dr. Jignesh, Dr. Mohandas, Dr. Anju. They are really very great. And Dr. Sudha Sharma I have also. मतलब I'm really fan of them. अगर इनको सुनो, जितनी बार सुनो, you always get something because it is my passion to learn each day. मैडम मैंने FOXI academic society भी बना रखी है. Whatever the important points are there, it will be floated in after the webinar within 24 hours in that. So all the members are being benefited and everybody shares his or her opinion in that. Thank you so much, Dr. Shobna. Kindly go ahead with your talk.
And now I request Dr. Shobna ma'am to go through with her talk. Shobna ma'am.
Madam, I think you are mute. Shobna, madam, I think you are mute.
Shobna, unmute.
Shobna ma'am.
Ma'am, I think ma'am is trying to share the PPT as such.
But ma'am का PPT तो
हो
share
गया, unmute हो गया. Ma'am is unmuted, ma'am.
परमा फोन कर लो.
नहीं ma'am unmute हो गया है ma'am. Mr. Vishal.
Hello, can you hear me now?
Yes ma'am.
Yes ma'am. अपना PPT
Oh,
ma'am.
Yes.
I was just saying thanks to Kanpur Society for inviting me here, and I'm humbled by so many stalwarts sitting and listening to a basic talk on MHT, and I apologize for the basic material that is there in it. Well, let's enjoy each other's presence here, and I will learn from you after my talk. You can give me inputs. So thank you, Kanpur, once again for calling me. Well, hot flashes is is there in 85% of women in one study in an Indian Menopause Society. The second study will be ending by the end of this year, I hope, and we will have some data this year how frequent it is. So the duration can be 5 seconds or if it is very severe, it is coming every 10 to 30 minutes. If it causes insomnia, you have to come out with your medicines. You know why it happens? It happens because of fluctuations in estrogen levels and not the nadir or top. The nadir comes after 60, but the fluctuations happen around 50, and that is when you get hot flashes. Once the fluctuations lead to a nadir, you do not get hot flashes. The fluctuations makes the hypothalamus confused, and the thermoregulatory set point is kept down below, because when when you're confused, you act fast. So when there is a temperature rise, immediately the hypothalamus acts because it is confused because of the fluctuations. And so it is at this point of time that you have to give MHT. What you mean by MHT is estrogen or estrogen progesterone, tibolone or bazidoxifene. This is what you really think as in MHT. A minute, let me just make my thing vibrate. Yeah. So this is what MHT is. When the uterus is not there, you have to give either conjugated estrogen, estradiol valerate, or just estradiol, as depending on the preparation that your company has. Micronized estradiol is also there with this Walter Bushnell. So all these preparations can be given. And when the uterus is there, you have to add progesterone to it. My slide is not moving. Yeah. So when the uterus is there, you have to add either medroxyprogesterone, the old favorite, or the later ones, new favorites like dihydrogesterone or micronized progesterone have to be added. So the regimens can be cyclic. That's what most of us are giving. Last 10 to 14 days, we give progesterone. Cyclic combined can be there where you give it 1 to 25. New preparations are there where it is totally given estrogen progesterone for 28 days. That Conti preparations are all there. So low dose are also there. And intermittent combined is there where you give repeated cycles of 3 days on, 3 days off. All these things are there. But most of us are comfortable with our cyclic regimens. We can switch over to the combined regimens that is there. And now you have to I can't see the top. The conjugated estrogen comes with from the horse's urine, or the other estrogens. My slide is not moving. Yeah. See, conjugated estrogen is a combination of many types of estrogen. 17-beta estradiol metabolizes to estrone, estriol, and estriol sulfate. Estradiol valerate gets converted to the esteriform form of natural molecule and metabolizes in the liver to 12-beta estradiol. So this is what acts. Now, the one in the oral contraceptive pill is that is a ethinyl estradiol. It is very strong. It is a hatha-kata molecule. It will not go away from your it will not get hydroxylated, and it won't go away from your body. It will last a long time, and it is 4 times as potent. Oral estriol, our good old days when we were doing MD and all, this is a very weak estrogen. It's not used that much anymore. We have to understand that one OC pill containing just 20 microgram of ethinyl estradiol is equal to 4 tablets of conjugated estrogen. So that is a potency that therefore you have to avoid in people who are hypertensive and all that. You can give MHT to patients who are having hot flashes, but you can't give OC pills to those patients especially when they have migraine or hypertension. Otherwise, obese people and all, you can give your MHT, not ethinyl estradiol. Now, what is a vis-a-vis doses? You have those gels. They have 2-meter doses with 1.5 milligram. That is equivalent to 1 milligram of your 17-beta estradiol or 0.625 milligram of your conjugated equine estrogen. Vaginal preparations are even very, 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 very weak. Can you imagine? 0.5. That is all that is there in vaginal estrogen. That's why you don't even need progesterone as a backup when you're giving vaginal estrogen. And conjugated equine estrogen is 0.3125 dose equivalents. So that is why you don't need a progesterone. Now, one word about transdermal MHT. It's costly. It's not very commonly we're not prescribing it. But if you are very rich, it does not modify markers of coagulation. You won't get a stroke that often. More favorable effect on triglycerides, does not increase the incidence of stroke. eliminates hepatic first pass metabolism, and much lower doses are necessary to alleviate the symptoms. Provides a more consistent levels of hormones. So if you have a lot of money, instead of spending it on saris, you can spend it on the proper MHT, if at all. But people won't stick to it for long. If you give a costly preparation, they will drop out much faster. That is a side effect of giving a costly preparation. But yes, you have to tell you what is right and what is wrong. This is how they apply it. You just take this thing in your hand and then apply it on the hand. And 2 meter doses are given. And if necessary, you can apply it on the feet also if you need more than 2 meter doses. So this is how you give it. So 1.5 milligram, let's repeat, for mild symptoms, just 2 meter doses are enough. And if the tube will last 26 days, cost around 2,000 rupees. So the point is, when you do not have a inherent health hazard, you're just feeling hot, it affects your quality of life. But it does, you feel inadequate, you feel lack of confidence, only that is there, then people may not, spend that much of money. So they will go for a cheaper preparation, oral preparation, this thing. Because if you're saying you're going to die, you're going to have cancer, then you will go for a costly preparation. When it's just affecting your lifestyle, you may go for a cheaper one. But the transdermal ones, as I told you, can be given in all these conditions like diabetes, hypertension, obesity, smoking, everywhere you can use it. Now, what about progesterone? It is an integral part if your uterus has not been knocked off, because you have to protect the endometrium, and various progesterones are available. So the dosage differences I have already told you, dihydrogesterone 10 milligram or MPA 5 milligram, that is half tablet of the one which you normally use. And vaginal micronized is 200. Okay, so this is the vis-a-vis doses, dihydrogesterone 10 milligram. You have levonorgestrel also, you have a preparation called Skyla that's available in UK, that's giving you half the dose of the drug that is necessary for stopping bleeding. Please understand that most of the estrogen receptors are on the ducts and the progesterone receptors are on the lobes, and therefore the cancers are mostly lobular carcinomas, and that's the progesterone which is causing cancer, not the estrogen. And the progesterone receptors are affected, and that is causing the paracrine mode of proliferation to the apocrine mode of proliferation. But all progesterones are not same in this, Natural progesterones, micronized progesterones, dihydrogesterone, drospirenone, all these do not have androgenic or estrogenic action. It is a more favorable molecule, especially for obese and hypertensive patients. And it is known that the risk of breast cancer is higher with medroxyprogesterone acetate, levonorgestrel, and norethistron. It is lower with dihydrogesterone. So it's worth paying more not to get this thing. But the point is, you have to give it for 5 years to get an increase of the CA breast that you already have, and once you stop it, that risk is anyway gone also. So, sleep loss is a problem in menopause, and natural progesterone gives you better sleep. And this is proved in studies. And vaginal progesterones are also available. You can apply even little lesser progesterone, so you'll get less chance of getting breast cancer. And more drug reaches the uterus directly. So all these things are available newly. These are new things. So, and there will be lesser systemic side effects. So what Dr. Kiranji was talking about, the WHO trial, after 5.2 years, they had to stop it. There was more incidence of people dying of stroke. That's because more older women were recruited in the study. Why? Because in the age 50 to 59, estrogen improves the blood lipids. But in the older age, when the plaque has already been formed, the pro-thrombotic effect of estrogen will go and sit on the plaque and increase the size of the plaque. So even in spite of improving blood lipids, the pro-thrombotic action will increase the size of the plaque and cause stroke. That is why all those older women recruited in the study were getting it. So if a patient at 60 comes to you first time with hot flashes, would you start giving HRT? I would say no, although the NAMs are saying that you can start giving it up to 60 now, but I think it can be continued up to 60, but starting at 60, I don't know what the NAMs will say. I think Mamja madam will explain. And in that, when they come to you first time, they said you cannot start it after 55. Whether you can start it or after 55 according to NAMS, which has come 6 days before, I don't know. But definitely continuation can be done after 60 also. That's what Madam has just now told us. Now, is the fear of cancer overplayed? You know, Indian Menopause Society guidelines have said that more than 4 years, there is a associated with the risk of detection of cancer risk. It does not initiate cancer. Only if you already have cancer, it will increase the size. That means you will detect it much faster. In fact, it is better that it is detected faster. And the perception is that all types of HRT causes it, but the truth is that even in WHI trial, only estrogens given did not increase the incidence of cancer. Estrogen is not the culprit. And the risk associated with drinking alcohol, becoming obese and all that, so your way of dying of all these diseases is much higher than your risk of dying of breast cancer caused by HRT. Now, when a patient comes to you, you should know how to give the drug. If the patient has got mild GIT symptoms, you know it's because of your tablet. Tingling and swelling of the breast, you have to reduce the estrogen. Endometrial bleeding, headaches may increase. You know, she never had migraine. Suddenly, when you start this tablet, it starts. And after 78 weeks, when you even forget that the patient has been given HRT, she may get inflamed pancreas and she'll go to the GI surgeon. And actually, it may be because of your HRT. So you have to even check that, that you may have to go and check your liver function. Keep calling her back. Otherwise, when she gets a tummy ache, she'll forget to tell the GI surgeon that she's taken it. So you have to know it. Increased factor 8, we already told you, can increase deep vein thrombosis. Dry eyes can happen. Increased triglycerides with oral drugs, decreased incidence with transdermal ones, only it's costlier. Melasma, macular pigmentation can be there. Increased microalbuminuria. Drug dependence. People who are happy with this thing, they can't stop it. You say NAMS is given up to 60, but now at 70 also they will say, I don't want to take it. It becomes drug dependent, especially in surgical menopause patients. So when to decrease the estrogen? Breast tenderness and bleeding. That's very common. You give the prescription, they go abroad and they call you and they say, I've got bleeding, what to do now? Irritability, depression and all that, then don't say it's because of your age or because of your husband. It may be because of progesterone. So you have to change the progesterone. So breast tenderness, reduce estrogen. Strictly reduce the salt intake. Don't tell them to cut down the pickles and all that. Caffeine and chocolate. And you can change the progesterone. Fluid retention, all the blouses are not fitting anymore. And there you can switch over to a lower dose progesterone, lower dose transdermal estrogen, switch to micronized progesterone. So your old blouse will again start fitting. So mood changes, I told you, you can actually switch over from systemic progestin to LNG-IUS. That's like, it will stay put and you will have less problem. You can even change over to Tibolon. A dose as small as 2.5 milligram dihydrogesterone with 0.5 milligram 17 estradiol is effective. See how small the dose is. Still, it is known to be well tolerated. So, if you have GI symptoms, tell them to take it at night or change the preparation. One word about GUS. We have a lot of patients with dysuria, wall prolapse, and everything is there. It's because of estrogen. And because there are estrogen receptors everywhere, and therefore, after menopause, there is a lack of rugosity, and estrogen causes better closing pressure. So all sorts of GI vaginal atrophy starts there, and you can give vaginal cream, vaginal tablets, vaginal capsules, vaginal drink, or rarely even oral ones. So vaginal creams are either estradiol or conjugated estrogen. Vaginal tablets, plain estradiol is available abroad. You can get it from abroad. It's given everywhere, but here it did not catch up and the company withdrew it, Dose is 2 to 4 milligram for once daily and then twice weekly and gradually taper to 3 times weekly. You can even give it up to 2 years and you do not have to give. Conjugated estrogen is half to 2 gram daily intravaginally depending on the severity of the condition. So estriol cream is also there, 1 applicator full twice weekly. Now, it stimulates the superficial and intermediate cells. It does not change the endometrium. That's why you do not have to give progesterone. And you have to start therapy before there are irreversible atrophic changes. That's why some old women, when you start giving it, it doesn't work because a full endometrium is totally atrophied. Sometimes it will not work. And there you will have to give, even if the estradiol levels are even higher in the plasma in spite of local application. You know? Suppose a patient comes with hot flashes and she is already on oral estrogen. Do you have to give vaginal? Yes, you have to, because it will help in spite of the oral one. Stress incontinence, for God's sake, will not improve with local estrogen. In fact, with menopause, a lot of people who had stress incontinence in their middle age will have less incontinence when they are in menopause without estrogen. This is a very common thing that we see in our population. That you ask them to get surgery at 35, at 50, they said, I didn't get operated, but now I don't have a stress. So do not give estrogen for stress incontinence. Now estrogen is market. You know what? Let's go away from estrogen to other molecule. Let's go away from progesterone. In 1940, estrogen was marketed. Then there was a lot of bleeding. In 60s, they added progesterone. But progesterone, what it caused breast cancer. And so they had to have a drug which is specific, do all that the estrogen does. So what did they do? 25 years later, they found Tibolone in 1989. But still, they took a long time to actually give it a name called its selective tissue estrogenic activity regulator. What does it do? Immediately when it goes into the liver, it gets converted to estrogen, androgen, and progesterone. So you have an all-in-one molecule. Best part is what, you know, it will give you all that the estrogen does: bone, flushes, lipid levels, sleep also. And it will, because it's got androgen, it will improve your libido. That's the best part about it. And the lipid levels are not affected, lowers the levels of HDL, and decrease in fibrinogen and factor VIII activity, increases in antithrombin and plasminogen, with overall trend towards increase in fibrinolytic activity. But if a patient has got stroke, you can't say that I won't give her estrogen, I will give her Tibolone. No, that studies do not allow that. We do not know the status of cardiovascular protection. Dose is 2.5 milligram per day. The point is, if you start 1 year after menopause, you won't get bleeding, but otherwise it's definitely supposed to be a molecule which causes less bleed. You know, it's supposed to be a bleed-free hormone. But yes, it's better to start 1 year later, you know. But if it is there, you just reassure, you know, unless it's excessive. So it doesn't matter, put a tap pad once in a while, so what? It does increase the incidence of stroke. And it may decrease body fat, you know, so you can use it in obese women. So you don't have to give your progesterone so your blouse won't get tight. That's one thing good about your Tibolone. So when there are things like insomnia, nervousness, disinterest, fatigue, loss of concentration, and there is surgical menopause and there is lack of libido, Tibolone is the answer. It's a better one. And it does not affect the mammography. If you have a dense breast and things like that, you will have a problem when you give estrogen because mammography won't show the correct thing. So in dense breast women, Tibolone is a good thing. And there can be less joint pain, good effect on muscles because androgens are there, no? And reduces diabetes mellitus, MS. So there is reduction in colorectal malignancy and neutral effect on lung cancer. Diabetes, I think Anju is very passionate about diabetes and MHT. She will talk about it. There is actually, you can actually give it in diabetes and there is decreased fasting glucose and so you can give it in diabetes. Now, how long can you give it? In premature menopause up to the natural age of menopause. But in natural menopause, safety data is for 3 to 5 years. With only safety data is for 7 years. But in fact, even after 10 years, you can give it. Some studies are saying, but generally hot flashes are there only for 5 years, no? So generally 5 years will be enough for the patient. That's the main thing. You have to call them after 1 month, 3 months, 6 months, so that, you know, when they get a pancreatitis or liver problem, you have to check them. Look for weight gain, reduce the progesterone if she's gaining weight, things like that, you know. After 6 months, you have to do a liver function test, examine the breast and everything. BMD, if your town has got a BMD, you can do it. Every 3 years, it's good to keep your patient alive with you again and keep calling them, not just send them off. That's how you follow up the patient. Before giving your hot flash treatment, please understand, is she taking amlodipine? Is she taking raloxifene? Is she on clomiphene citrate because some infertility specialist has given it? Is she on nitroglycerin, calcitonin? Does she have anything like thyrotoxicosis? Check her thyroid levels. You always think they're hypothyroid, but does she have thyrotoxicosis? When you check for thyroid deficiency, you might actually find she's got thyrotoxicosis. All this is a differential diagnosis of hot flashes. In COVID, it is a procoagulant thing, and you are not supposed to be giving it or giving it with caution. So please check again all the triglyceride levels and things like that. Now, this is the COVID era. You have to be cautious with your MHT. Now, let's go on to bazidoxepine. You know what? It retains the efficacy of estrogens in treating symptoms, but you do not give progesterone. Therefore, this drug will not stimulate the endometrium. It is a selective estrogen regulatory drug. So when you give combination of estrogen with bazidoxepine, no breast cancer, no stimulation of endometrium, plus it does some work of estrogen, so reduce the dose of estrogen also. So that's how this bazidoxepine is a very good drug to give along with estrogen with a lower dose, just 0.45 milligram, So when you have a woman with premature menopause, it's very nice to go and give these OC pills, easy to give. And patients also accept it. But the difference is that if you have a patient like that, it's always better to give MHT than your ethinyl estradiol. But of course, there is no harm in giving it because there is data lacking on that. And contraindications are cancers, undiagnosed lumps, primary CVA, and inherent abnormalities of coagulation. So I think I am on time. If you are not really bored, the NAMs was taught by Ambuja madam, not by me, in something new. I only taught the old ones. So thank you so much.
Thank you, ma'am, for such an illustrative and descriptive talk. Now I request Dr. Sudha, ma'am, to give her expert comment.
Thank you so much, Dr. Shobna, for such, a crisp talk. I would say, you started with basics of estrogen and you have, ended with the latest one. I would say the latest one, the bazidoxepine and the latest drugs. Yes, you rightly said that OC pills should not be used in menopausal hormonal therapy because they are the synthetic hormones and they are more potent and they have extended half-life. So whenever you think of MHT, think of semi-synthetic or natural estrogens, not the synthetic ones. Then, today the topic we are discussing is menopausal hormonal therapy. Earlier we used to call it as a HRT, hormone replacement therapy. You know why? Because menopause was always thought as a hormone deficient state, like the thyroid deficient state. You have insulin deficient state. So it was always thought as the hormone deficient state. So the term used was hormonal replacement therapy. So if we go back, in early 20s or 30s or 40s, hormonal replacement therapy was, so common that all these drugs, they were available on the counter. Not to talk of India, but abroad, every second female was using this drug on the counter. They would just go buy it. They just wanted to remain, young, feel young, have the menstruation. And the concept was, if you take it, you will remain feminine forever. So the concept was feminine forever. Even FDA approved estrogen for, menopause therapy. Then slowly, FDA approved this, estrogen for osteoporosis. So the concept shifted from feminine forever to the healthier forever. The, drug HRT use again, it increased like anything. So millions and millions of women across the world were using this menopausal hormonal therapy, first for, to remain young and feminine forever. Second, for healthy forever. Third was for preventive therapy as osteoporosis, as heart disease. So they would give menopausal hormonal therapy thinking that whenever, once you are in premenopause, so this estrogen is protecting your heart. So why not to take it post-menopause? So three, uses were there. So the HRT was rampant and HRT use was so common till this Women Health Initiative study came into limelight. And this study has been, we cannot ignore this because this is one of the largest ever study which has been done on menopausal females. Randomized, double-blind control, and RCT trial. It was done in, so many 17 or 18 centers, 16,608 females. They were, recruited for this study. And this study, it had two arms, and not to go in details. One was, for 5.5 years, and the second was where only estrogens were given in hysterectomized females. That was supposed to end for 7 years. But, after it, this study was, stopped prematurely because they found that the number of stroke patients increased, number of cardiac heart disease increased, number of breast cancer increased. So the study was, halted, and the consensus was made. It was published without, knowing all the facts about this study. So what they found that the risks are more than the benefits. All the females, all the doctors, all the paramedics, all the, gynecologists, they stopped prescribing, they stopped taking this drug all over the country. But slowly and slowly, what happened, they found that there were so many pitfalls in this Women Health Initiative study, and some of them have been very beautifully highlighted by Dr. Shobna. Same drug was used, same salt was used, same route was used, and then the female were in the later age of menopause. Now we have extended study of Women Health Initiative study. Many organizations, they have done these, all those females who were recruited in the study, they have given consent, then they will continue with the drugs. And now what they have found over the years, that when you change the salt, when you make it individualized, because something which suits me cannot suit you. So it has to be a tailor-made therapy. It has to be individualized. It has to be, the safer drug. Now we are using 17 beta estradiol because they are biologically similar to, the ovarian hormones and the better progestrogens. And still we have, many indications where we can use menopausal hormonal therapy. We are using menopausal hormonal therapy. And very rightly, Dr. Ambuja has said that this national NMS, it has, given this position statement in 2022. Some panelists, they have been recruited, and expert panelists, they have given DHEA and the bezidoxifene, also the salt. So this humble appeal to everyone, to all the gynecologists sitting over there, that our Indian Menopause Society also, the guidelines, they tell us how to give, when to stop, how to follow it up. So if a patient is suffering from, strong vasomotor symptoms, local symptoms, surgical menopause, please don't deprive her of all menopausal hormone therapy. Just don't tell her that, nahi, ye theek hai, ye ho jayega, ye phase chala jayega. Give her a quality of life and give her menopausal hormone therapy. So thank you so much. Thank you, Kanpur Menopause Society, for inviting me and making me a part of it.
Thank you, ma'am, for sharing your vision. Now heading towards the second session.
Very, very crisp presentation. It was really good.
Thank you so much, madam.
Whatever sentence you told, it is really worth listening. When to start, when to give, how much to give. Really excellent presentation it was.
Thank you for appreciating. Everybody who has appreciated. Your words are really precious for me. Thank you so much.
Yeah, you see, you did it. It is not the appreciation. how much important, it is not the subject that is there. You made it so, understandable to everybody. You made when to give, when not to give. Really a very good presentation and very nice it is.
Thank you.
Yes, ma'am. Now, heading towards our next session, MHT in comorbidities. I will like to invite our learned chairperson, Dr. Pragya Dhiravani and Dr. Kanchan Sharma, ma'am. Dr. Pragya, ma'am, is a very sweet, sensible, and beautiful. She is a laparoscopic and hysteroscopic surgeon, senior obstetrician and gynecologist at Jabalpur Hospital and Research Center. Currently, she is president of Jabalpur Menopause Society, and she is also past president of Jabalpur Obs and Gynae Society. She is recipient of many awards, and she is organizing chairperson in West Zone Yuva Foxy Jabalpur in this year. I welcome you, ma'am, Pragya, ma'am. Next, Dr. Kanchan Sharma, ma'am, is very energetic and enthusiastic secretary of Kanpur Obs and Gynae Society. She is director and chief consultant of Akash IVF Center, Kanpur. She has a special interest in ART and embryo handling. She is organizer of many national and international conferences of gynecology and many webinars after joining as a post of secretary, Kanpur Obs and Gynae Society. I welcome you, ma'am. Now I request Dhirvani ma'am to introduce our speaker, Dr. Anju Soni ma'am. Expert will be again Sudha Sharma ma'am.
So, good evening, one and all. Our guest of honor, respected Dr. Ambuja Madam, Dr. Jignesh Shah, and I'm very much thankful to the Dr. Kiran Pandey, Professor Dr. Kiran Pandey, President KMS, and Secretary KMS, Dr. Garima Gupta, for giving us the opportunity, me and my co-chairperson Kanchan Sharma, to chair the session of an eminent speaker, Dr. Ambuja Soni, Dr. Anju Soni. Dr. Anju Soni. She is a chairperson HIV and AIDS Committee, FOXY, for the year 2020-23, the Secretary General IMS for the year 2022-23.
Thank you, Dr. Pragya. I don't think we should waste time.
I think if I read the whole CV, the time for the talk will be less. So I invite Dr. Anju Soni to deliver her talk on HMT in comorbidities. Very, very important talk.
Thank you, Dr. Pragya. अंजू अभी आपका स्टार्ट हुआ है, शेयरिंग अभी हुआ नहीं है.
Welcome, Anju ji. I have heard a lot, many times to you. You are a wonderful speaker.
Are my slides visible?
नहीं अंजू अभी नहीं है.
Oh, no.
नहीं है.
है विजिबल है मैडम, लेकिन अभी फुल स्क्रीन में नहीं है.
नहीं ये स्लाइड नहीं है बेटा, ये सीवी है उनकी.
नहीं वो तो ठीक है, पर मैं नहीं, पर वो प्रेजेंटेशन मोड में नहीं है अभी. एक मिनट.
अच्छा हाँ, अभी वही अभी प्रेजेंटेशन मोड में नहीं है.
एक सेकंड, ये क्या चक्कर है, मेरे को दिख रहा नहीं है.
हेलो
हाँ
मैम, अंजू मैम इसे फुल स्क्रीन कर लीजिए मैम.
फुल स्क्रीन कैसे करूं बताओ
मैम. बॉटम में आपको ये जो माइनस साइन दिख रहा है ना, 87 जो लिखा है ना आपकी इधर, उसके बाजू में जो बटन है उसे क्लिक कर दीजिए.
अभी नहीं दिख रहा, पहले दिख रहा था. कहाँ गया
मैम? बॉटम में आप देखिए 87 आपकी स्क्रीन में जो है 87 लिखा हुआ है ना.
लिखा हुआ था पर अभी वो चला गया.
आप पीपीटी फिर से खोलिए मैडम.
अच्छा एक मिनट
मैम, एक बार F5 ट्राई कीजिए.
F5 कहाँ पर है?
ऊपर, सबसे ऊपर
फंक्शन कीज जहाँ होती हैं.
अच्छा पहले इसको खोलूं एक बारी.
स्लाइड खोल के एक बार F5 प्रेस कीजिए तो वो स्लाइड शो में आ जाएगा.
F5 किस ऊपर कहाँ पर है, मेरे को एक बार गाइड करेंगे?
मैम
तो हमेशा
कीबोर्ड
नीचे
पे, आपके लैपटॉप के कीबोर्ड पे नीचे F5 के होंगे ना, F1 F2 ऊपर बने हुए हैं।
सबसे ऊपर वाली जो रो होती है,
तो एस्केप लिखा हुआ है।
हाँ,
उसके बाद आगे बढ़िए उसी में।
एस्केप के आप राइट हैंड साइड पे जाएंगे तो F1 F2 F3 लिखा रहेगा।
मैम सेम की पे सिंबल्स भी बने हुए, स्टार के, फिर F2 फिर F3।
नहीं, वो तो साउंड्स के आ गए, साउंड आ गया, लाइट आ गई,
फिर उसके बाद है
लेफ्ट कॉर्नर अपर कॉर्नर में मैम F4 F5 लिखा रहता है।
नहीं दिख रहा मेरे को।
मैम फिर ऐसा कीजिए, ये जो ऊपर टैब्स है ना, होम, इंसर्ट, डिजाइन लिखा हुआ है।
एक मिनट, मेरे को आपका नीचे वाला दिख रहा है।
87 वाला दिखा मैम आपको? हाँ
और
हाँ
नीचे मैम, और
मैम नीचे आइए।
और नीचे थोड़ा।
87 उधर नहीं मैम, इधर मैम आप
माइनस पे जाना है मैम, माइनस पे।
नहीं, माइनस पे नहीं जाना, इसके और
माइनस के उधर।
मैम उसके आगे नहीं, उसको मत दबाइए मैम।
मैम लेफ्ट।
मैम माइनस के आप लेफ्ट में जाएंगे, 60% लिखा है ना।
हाँ 60% लिखा है।
उसके लेफ्ट वाला जो आइकन है ना, वो दबा दीजिए आप बस।
लेफ्ट
60% के लेफ्ट वाला,
उस साइड में, अपोजिट साइड में, अपोजिट
दूसरी साइड में मैडम।
हाँ ये ठीक है।
नहीं मैम,
नहीं मैडम,
तो
माइनस की तरफ आइए ना, आप जहाँ पे 120% लिखा है उसके
और
लेफ्ट
आगे
साइड में।
चलिए, और चलिए, और चलिए, बाएं साइड में।
मैम लेफ्ट साइड।
ये लेफ्ट ही तो है। ये माइनस प्रेस करते हो तो छोटा जा रहा, होता जा रहा है।
नहीं, उसको नहीं दबाना है मैम, उसके आगे 50% पे आइए मैम, 50% पे जो लिखा हुआ है 50% मैम।
आज तक की प्रॉब्लम हुई, क्या हो रही है?
मैम पॉइंटर को ना आप जो ये परसेंटेज चेंज हो रहा है ना, इस पे लाइए और इसके जस्ट बराबर वाला जो आइकन है उस पे प्रेस कर दीजिए।
बराबर कोई आइकन है ही नहीं।
फिरोज जी ऊपर से आई थिंक मैम कैन डू स्लाइड शो डायरेक्टली चला देंगे ना, उस पे भी हो जाएगा।
मैम व्यू पे जाइए मैम।
हाँ व्यू पे आप जाइए।
आज तक की प्रॉब्लम नहीं हुई, आज ये पहली बार हो रही है।
कोई नहीं मैम, हो जाता है मैम। आप ऊपर या तो चले जाइए जहाँ पे होम इंसर्ट डिजाइन लिखा हुआ है,
वहाँ व्यू पे चले जाइए मैम, व्यू पे।
हाँ डिजाइन है ना, डिजाइन के पास कहाँ पे?
मैम उसके आगे एनिमेशन, फिर स्लाइड शो, फिर रिव्यू, फिर व्यू, तो व्यू पे जाना है मैम।
अच्छा एक सेकेंड, हाँ गया मेरा आइकन, खो गया। हाँ व्यू पे गई,
प्रेस करिए मैम। मेरे को
टिक कर दिया, वो तो कलर दिखा रहा है खाली व्यू पे।
मैम स्लाइड शो पे फिर करिए।
मैम स्लाइड शो पे आइए,
स्लाइड शो पे करिए मैम। फिर मैम रिव्यू लिखा है। नहीं कोई नहीं मैम, रिव्यू के बगल में स्लाइड शो लिखा हुआ है मैम।
हाँ
इसको प्रेस करिए।
कर दिया
मैम। इसका पहला
फ्रॉम बिगनिंग, यहाँ से जहाँ फाइल के नीचे एक आइकन बना है फ्रॉम बिगनिंग।
फ्रॉम बिगनिंग
मैम फाइल के नीचे, फाइल के नीचे।
हाँ हाँ हाँ
जी
फ्रॉम बिगनिंग
जी
मैम अब आ जाएगा।
ठीक है, थैंक यू सो मच। So I'm sorry for this. These IT things happen to everyone. And at the office, I like to thank Kanpur OBGY Society. And Kanpur for me is my, I call it my here. But my chacha used to live here, and I have visited Kanpur many times to him. And it feels really, really nice being here. And I'm thankful to Kiran and the
Dr. Anju, I think your net is.
I think video बंद करके करे तो शायद ज्यादा।
If you switch off your video, that would be.
मैं नजर नहीं आ रही थी क्या?
नहीं आप नजर आ रहे थे, लेकिन स्क्रीन चली गई। और अनदर थिंग कि नेट का वो कम है बैंडविड्थ, तो आप अपना वीडियो बंद करके अगर
आप शेयर भी कर सकते हैं। रंजीत, मिस्टर रंजीत आपको मैम सेंड कर दे तो आप डिस्प्ले कर दीजिए मैम का। मिस्टर रंजीत।
ओके मैम, ओके मैम।
मैं मोबाइल हॉटस्पॉट पे ले लेती हूँ एक बारी, एक सेकंड दो मेरे को, फिर प्रॉब्लम नहीं होगा क्योंकि मेरे यहाँ पे सिग्नल बहुत अच्छा दिखा रहा है।
अब आप मेल भी कर सकते हैं तो मिस्टर रंजीत डिस्प्ले कर देंगे।
नहीं मैंने मोबाइल हॉटस्पॉट पे ले लिया, मुझे प्रॉब्लम नहीं होगी अभी। अब तो मेरा ठीक हो गया, मोबाइल हॉटस्पॉट पे आ गया. आई एम शेयरिंग द स्क्रीन अगेन. Am I visible now?
Yes, ma'am.
Yes. Yeah. So I am thankful to the chairpersons for their kind introduction and welcome all of you, Dr. Sudha and each and every person present here. Going further, my slides are visible now?
Yes, ma'am.
Are
Yes.
they moving?
Yes, yes, and we can see, we can hear you very clearly, Dr.
Yes.
Anju.
1 second, my mobile. Let me move to silent. Yeah. So MHT with comorbidities, my 90% job is done by Dr. Shobna Mohandas. She's given a beautiful overview of MHT, and I don't think I will have any problem when I go through my presentation. So thank you, Dr. Shobna, for making a good pavement for me. But whenever we talk of anything which is not normal, no, it is normally, very great to walk on a paved road, but it may be comfortable to walk, but no flowers can be grown on a paved this thing. So we have to face the difficulties. So there are conditions where we face difficulties, where we feel dilemmas that how do we treat these patients? Should we give them any treatment or should we not give them any kind of treatment? And of course, whenever there are, already morbidities associated, there is always a risk of managing these problems. So let's continue the talk. And when I go through my presentation, I'll be talking about different points, avoiding MHT, which are the situations, MHT post endometriosis, with fibroid, with heart disease, with the DVT, irregular bleeding, Parkinsonism, renal failure, and so on. So when to avoid MHT? We all know that whenever there's an unexplained bleeding, there is stroke, TIA, or this MIP, or VET, or there is a breast or endometrial cancer, and or a patient is having active liver disease. So in cases of cholecystitis and cholestasis and hepatic adenoma, no MHT. When a patient has got SLE, there are RCT trials which say that it will flare the disease. And whenever there are porphyrinias, again, you will have to, because porphyrins are built up, again, it's a precursor of heme, leading to CNS and skin disorders. And it is said that it can give rise to abdominal pain, chest pain, vomiting, confusion, constipation, fever, etc. So estrogen and progesterones can exacerbate the attack. So no to MHT in these cases. So what is the choice of MHT in post-endometriosis? Here is a case, a 50-year-old woman. She a high-profile job. She went TH with BSO. She had fibrosis and endometriosis about 2 months ago. She presents with hot flashes. The most common problem I think all of us face, but are not able to share or take it as a part of old aging. Now, her gynae gave her soya and tofu. There was no relief, of course. She again came for second opinion, and she was found to be clinically normal. Now, should the ovaries be removed? That is the first question we must answer. If yes, why? If not, why? The ovary continues to produce androgen after menopause, which is useful for bone and mood and libido. So, any other case, excluding this, we should not remove ovaries. What about the tubes? Yes, they should always be removed because to avoid hydrosalpingo, and most of all, it is said that it prevents carcinoma of ovary. So what should be the management in this case? And after counseling, we chose to give her a hormone therapy. Now, the next question is which one and what regime would you give her? So in these cases, we all know that, a woman is quite often forced to have hysterectomy with bilateral salpingophractomy because she is really suffering with the disease, and we should be routinely put on AHRT? Yes, if they have got symptoms. It is known that endometric implants may be present even after hysterectomy. So progesterone protection is very, very necessary. So we have to give these women a combination of estrogen and progesterone, or we can switch over to Tiburon. Dr. Shobna had just said the many advantages of Tibolon, which has estrogen, androgen, as well as progesterone, and at least it should be given up to the natural age of menopause. Now, again, there is another problem that most of the women may come with fibroids and which are not giving her any problem, and which for that we don't normally tell them to go have hysterectomy. So, but there are no good studies available in this, and there are some studies which show that there is definitely increase in size of fibroids when we give them HRT, and there are studies which shows that the increase of fibroid is there, but these women were not symptomatic because of increase of size. So HRT in patient of fibroid, in a 3-year study, there was a study done where women with or without fibroid were given HRT, and in first 2 years the volume increased in HRT group, and in the 3rd year the increase was not marked, and at the end of 3rd year study it was seen that 35, 34 and 33 out of 34 women, the increased fibroid volume was 25% compared with the baseline to the HRT non-users and respectively. But this does not stop us from giving her the HRT. It can be given safely, so there is no harm. So what about postmenopausal hypertensive patients? Again, patient comes, most of the patient in our country, because of their obesity and PCOD and many other problems, have, and early menopause have hypertensive disorders. It has been found that more than 90 to 95% of women past 60 years have hypertension. So these patients again put a dilemma in our mind. So it has been seen that 60 women with hypertension with 24 recorded hours of recorded BP around the age of 50, and they were put on transdermal continuous HRT in a sequential regime, and other were put on placebo, followed up at 3 months, 6 months. There were no significant variation in systolic and diastolic measurement with the standard, measurement detected in the both groups. And 24-hour BP was less in the treatment group. So this decrease in dynamic BP was significant for both systolic as well as diastolic BP, because the estrogen has a vasodilatory effect. They increase the bradykinin, increase the nitric oxide, which further, MHT in standard dose is beneficial in improving the hypertension. So, of course, OC pills, as has already been emphasized many times, I would like to reiterate, should not be considered as a part of MHT. So MHT and heart disease is another dilemma for us to deal with, because 47-year-old woman who came with multiseptated 15 centimeter ovarian cyst, 5 centimeter fibroid. She had only edema feet as complained. Her hemoglobin was 7. She was scheduled for LA with BSO. Routine checkup showed that she had left ventricular dysfunction and she underwent TAH with BSO. Now, should she be put on hormone replacement therapy prophylactically? These are the questions which comes to our mind. And if she develops hot flashes, can we give her HRT? Again, another woman, 60-year-old, history of CABG for CAD 2 years ago, complained of night sweat, nocturia, frequency, urgency, joint pain, backache. Urine routine showed some WBC 15 to 20, no growth on culture, and her fasting level were 102, PP 136. Her T scores was less 1 point, in the osteopenia. And she was on hormone therapy before surgery. Want to go back on hormone therapy? As Dr. Shobna said, they get addicted to the drug. So what would you do? Of course, we will tell her to first go to lifestyle management, then estrogen cream and bisphosphonate and hormone therapy again a query. In surgical menopause, routine hormone therapy is not recommended in for primary prevention of chronic conditions, and it should be considered only in women who are less than 50 years who have gone a surgical menopause or below in premature menopause. And heart failure need not to be contraindication for HRT if patient is severely symptomatic. So we have to tailor-made and accordingly decide. We can't give HRT or MH to each and every person and go ahead with it. So we have to choose and give to accordingly. Another best study, in this case, patients, a trial was done with beta blocker for 102 women who were taking HRT, and outcome on HRT on heart failure could be assessed. And it was seen that, in the patient who were on beta blocker and on placebo, 102 were using HRT, 333 or no HRT. And it was seen that, it was 435 women were at the age of 50 and older, and 21% died in the beta blocker group, and placebo 34% died, which showed that it was beneficial to be given in the patient of heart failure. So significant difference in survival favoring HRT use. So far, it can be given in a perimenopausal period. It is good for heart, it is safe, and may be beneficial in hypertension. And if started first time in a woman who is more than 10 years post-menopause, can be detrimental. And in hysterectomy woman more than 55 or years of age and lipid-friendly progesterone are better for use. Evidence says that there is no role of hormone therapy for secondary prevention, and secondary prevention for CVD should be done by non-hormonal methods. Now, again, another very, very important problem which we face is, women may come to us with irregular bleeding which are on MHT. So, which are the situations which will cause regular bleeding? Irritable bowel syndrome, Crohn's disease, celiac disease, and poor drug absorption can, give to bad drugs, and this can be, cause of the bleeding. Then again, thrombocytopenia or patient on blood thinners like warfarin or high dose of aspirin can have regular bleeding. Then a woman on high dose of antibiotic, again because of intestinal hurry and poor absorption, which can give rise to poor effect and irregular bleeding. What about asthma? It has been seen that there is a small increase but there is no worsening of pre-existing disease. So it can be given in severely symptomatic women easily. Again, renal failure, it should be considered as there is increased risk of early menopause in these patients. So we have to, think about these drugs. Then again, Parkinsonism, it is said that it may reduce the risk of disease, and it is not contraindicated. Rheumatoid arthritis, it is felt to be beneficial because it, improves our bone health. Then again, MHT and DVT. What about this? It has been a 57-year-old female who had menopausal symptoms. Her LMP was 2 years ago. She had DVT following laparotomy and asking if she can start HRT. In these cases, we have to be very clear that these cases are high-risk cases, and we can either give them vaginal estrogen for their vaginal problem or shift them to transdermal estrogen, which are not contraindicated. Now, again, thyroid disease, it is not indicated. It is thyroid, it has at in menopausal age or perimenopausal age, it is seen that the TSH level up to 6 to 7 are normal. And in cases of hypothyroidism, there is increase in bone resorption. So it is beneficial in these patients. Then again, we sometimes come across with the patient who have transplant because of sorry for the interruption. Because of bone marrow transplant, chemotherapy prior to transplantation lead to destruction of ovarian tissue and thus premature menopause. Then there is a graft versus host disease along with the vaginal atrophy, which may lead to even occlusion of vagina. So these are the cases we must have a vigilant eye and give them a proper treatment as and when required. Then again, post-renal and hepatic transplant, the bone mass is lost at a rapid speed, especially it is intense in 6 to 12 months after transplant of a vasculated organ, and immunosuppressants are also responsible for this. And parathyroid hormone is also elevated in renal transplant. So these are the cases we have to keep an eye and accordingly manage them with different kinds of regimes. So women with combined ERT have significantly lower HbA1c level. They have dramatic reduction in plasma total cholesterol, low density of lipoprotein, increased HDL, and women on HRT have a lesser chance of diabetes, and women on HRT have a better control diabetes. Why I talked of this initially? Because I myself suffered a lot of with hot flashes for many years. I had severe, massive adenomyosis. For that, I had a TLH. And I suffered with hot flashes for years and years, and I went from pillar to post. And at that time, people, each and every person I went to refused to give me MHT. So I have, touched this earlier. We'll go into the detail in further slides. To summarize the previous slides, heart failure and hypertension are not contraindication for MHT. There is no role of secondary prevention for heart disease. Patients on transplant and rheumatoid arthritis will benefit from MHT, and fibroids are not contraindicated in MHT. So coming to diabetes and MHT, must understand what are the benefits. In type 2 diabetes, MHT improves glycemia, and women with diabetes mellitus are excellent candidates for MHT. And they can be given MHT oral if they do not have CVD risk, transdermal if they are obese or they have a moderate CVD risk. There are lack of evidence around the use of HRT in women with type 1 diabetes, which we need to study further and find out, because a lot of women are coming with this condition now. A woman in her early post-menopausal age has a history of migraine. What will happen to her migraine after menopause? This is a question in her mind. If she needs HRT, how can you give it? Because it is said that low estrogen levels and high FSH levels lower the prevalence of migraine after menopause, and absence of variation of hormone in postmenopausal women is very helpful. So estrogen withdrawal may lead to migraine in some patients, and a sequential regime may again cause migraine. So continuous MHT can be thought about in these women. Then again, another dilemma comes in cases of breast carcinoma. A 35-year-old woman operated for breast cancer. She is CEO of a company. Within 6 months, she went TH and BSO for the risk of ovarian malignancy. Complained of severe vasomotor symptom, vaginal dryness, dyspareunia, loss of libido. How do we treat her? Which is the ideal estrogen to be given? Another female, a 46-year-old healthy female, presents with complaint of severe insomnia, mood changes in last few months, increased emotional liability, crying outbursts, complaints of palpitation, fatigue, giddiness, insomnia for last 6 months. She experienced difficulty in falling asleep for many years, particularly in the weeks prior to her menses. When she usually felt weird about going to bed, worried about and irritable about everything, can't turn it off. During this time, she takes half an hour or longer to sleep. She also suffered from mood changes and perimenopausal period. Never saw treatment. It was severe enough to affect her job and concentration. It would go away when her periods comes. She used to think. Last period was 9 months ago. Her FSH was high, her hemoglobin was low, seen by neurologists, cardiologists, gynecologists, referred to psychiatrists. How do we manage her? So these are few of the cases. Now, in this second case, the differential diagnosis is anemia, anxiety neurosis, and perimenopausal syndrome. So in this case, we will put her on hormone therapy along with SSRI, fluoxetine, hematinics, and lifestyle modifications. And for vasomotor symptoms, non-hormonal first, and then we can put her on SNRI or SSRI, gabapentin, and of course blood pressure drugs and vitamin E, and patient on timoxine. Antidepressants are less effective. Now, another very important dilemma comes in cases of the women who are having dense breast, because in these cases, they're very scared. A 46-year-old woman, she She breastfed the baby. She had severe hot flashes, night sweats, insomnia, mood changes, loss of libido for last 18 months. LMP 10 months ago. Premenstrual breast pain, breast cyst, respiratory 3 years ago. Screening mammogram, benign dense breast. After WHI previous report, refused hormone therapy, preferring non-hormonal therapy. Unhappy with relief, came back again for consultation. Would you offer her HT? Her fears are her close friend had breast tumor. She was afraid that her cyst would produce pain or neoplasm. Although she did not want irregular bleeding, she was willing to accept a regular, predictable vaginal bleed. Her motivation was flushes, night sweats, bad sleep, mood changes, libido, loss, preserve good interpersonal relationship, regain normal performance work, increase mineral density. What are the preferred options? Going through the whole list, we all know that this patient, Tibolon, if she can afford, is the most ideal, and we must give her that. Then again, hormone therapy and breast cancer, there is no clear evidence that hormone therapy causes breast cancer, and overall risk for breast cancer while on hormone therapy is low. Women who develop breast cancer while on hormone therapy have better survival rate than those not on hormone therapy. A family history of breast cancer does not further increase the risk of breast cancer while on hormone therapy. Now, what are the risk factors for breast cancer? I would like to slightly put light on this thing. We all know that dense breast is one of the risks. Then the non-modifiable factors are age, family history, benign breast disease, BRCA carriers 1 and 2, early menarche, late menopause, increased breast density, and chest irradiation between the age of 25 to 55 years. The modifier factors which can be avoided are age at first child, breastfeeding, parity, obesity, to be avoided physical activity, and avoiding alcohol. So again, endometrial carcinoma, another dilemma for us, a 48-year-old para-1, live-1, active in politics. She had stage 1 type 1 endometrial carcinoma. She had THBSO 6 months back. A low-grade early stage 1 may consider MHT as indicated, and high-grade and advanced disease, an unfavorable histology, a type 2 carcinoma. Non-hormonal treatment should be given. That are the guidelines and practice guidelines. Again, MHT with ovarian cancer, Mrs. Vani, 39 years, diagnosed with carcinoma ovary at the stage 1 cell carcinoma during diagnostic infertility workup. Frozen section, fluid analysis, TH and BSO, omentectomy, staging lymphadenectomy done, post-operative chemotherapy given. She is asymptomatic for menopausal symptom. She is high risk for CVD, mild hypertension, on atenolol, raised triglyceride, mother had stroke, BMD, normal study. Issues, she has premature menopause and she has got cardiovascular problem. In premature menopause, hormone therapy can be prescribed up to the normal age of menopause. Further continuation of therapy is a shared decision between woman and physician according to the indication. This is a great evidence, and further studies are required for this. Then use of MHT in ovarian cancer, it is indicated in prior epithelial carcinoma except advanced series of endometrioid type because they are estrogen responsive. Sex cord tumors, again, they are estrogen positive. There is a limited evidence. Germ cell tumor can be given easily. Meta-analysis, 2 RCTs, 4 cohort series. MHT is not associated with difference regardless of cancer stage and type of MHT. This has been said. So our doctor's mission should not be to prevent the death, but more importantly, it should be to improve the quality of life. And this is, a quote saying, thank you very much for patient hearing. And
Thank you.
Thank you, ma'am. It was really a practical case-based approach of the topic, and to the point messages for the special situation for the MHT were very clear. Now I request Dr. Sudha Sharma ma'am to give her opinion regarding the topic.
Thank you, Dr. Anju, for this wonderful presentation, wonderful, excellent presentation, covering, all those conditions where one thinks multiple times whether to give, whether not to give, how to give, how much to give, and which sort to. You have simplified it in a very, very decent manner, and you have covered all the comorbid conditions that well controlled these conditions, they are not contraindication for MHT. Thank you so much for this.
Thank you, ma'am, for sharing her ideas. Now I request Dr. Kanchan Sharma, ma'am, to share her views on the topic.
First of all, I thank a lot to President IMS Kanpur, Dr. Kiran Pandey, Garima and Divya for organizing a wonderful webinar, and my regards to Dr. Jignesh, Dr. Ambuja ma'am, Dr. Shobna ma'am, and Dr. Sudha Sharma. Thank you a lot for joining us and giving us blessings, and thanks to Dr. Anju Soni, who is really a master of the topic and highlighted all the important points regarding MHT and in different condition, and especially by the examples of the age group different, as has been highlighted by Dr. Sudha Sharma.
मैं 5 मिनट थोड़ा सा एक उसमें करूं, तब तक मेरे लिए कोई और सिलेक्ट करिए.
Thank you, ma'am. Now we are well on time. It's time to deliver the vote of thanks by Secretary of Kanpur Menopause Society, Dr. Garima Gupta. It was really
Divya, I just would like to say one word.
Yes, ma'am.
And Dr. Anju, it was a very nice presentation. Actually, in such a short time, you covered so many varied situations where menopause hormone therapy can be used, well to use, just like Dr. Shobna, very crisp and specific, like asthma, what you can do, specifically heart condition where everybody is worried. So it was a very, very nice presentation. I'm sure it's going to be beneficial for each and everyone. That's a wonderful thing. Thank you, Ranju. Thank you very much for joining our webinar.
Thank you so much, ma'am.
Yeah, Garima, you can go ahead with the official thanks. I just wanted personally to thank Dr. Shobna and Dr. Anju and all our dignitaries.
Yes,
our privilege to come to you, madam. Thank you so much.
Madam. Anyone else would like to say something? Pragya ma'am.
Both the speakers were wonderful. We learned a lot and we have taken a lot of take-home messages. Very crisp and clear-cut guidelines. Thank you so much.
Definitely, ma'am. Definitely.
Thank you for coming in good numbers for such a topic which is oft repeated still. Madam, why do you think so? It is a very important topic. It's really most important. Dr. Sudha has also emphasized about it. Dr. Ambuja also. I mean, the basics are the most foundation where you can build up the big story.
Ma'am, there are no questions also in the chat group, so I will proceed with the official vote of thanks. Midlife is not the time for disenchantment. Rather, it's time to turn all our magic with wisdom. This was the crux of our today's webinar, in which we have attained various practical nuggets of knowledge. On behalf of Kanpur Menopause Society, I, Dr. Garima Gupta, Secretary, I am honored and privileged to deliver this vote of thanks today in front of our distinguished dignitaries and intellectually prominent gathering. Firstly, I express my profound gratitude to our guests of honor, ageless and divine figures, Dr. C. Ambuja ma'am and Jignesh Shah sir, for taking their time from their busy schedule and blessing us. Special thanks to today's eminent chairperson, Dr. Aarti Gupta ma'am, Dr. Kiran Sinha ma'am, Dr. Pragya Dravani ma'am, Dr. Kanchan Sharma ma'am. I'm very grateful to our learned experts, Dr. Sudha Sharma ma'am, though Pushpa ma'am couldn't come, for her exemplary insight on the topic. I must thank and congratulate our charismatic speakers, Dr. Shobna Mohandas ma'am and Dr. An event like this can't happen without vision and meticulous planning as of our Dr. Kiran Pandey ma'am, who is synonymous with perfection. And next I mention my deep sense of gratitude to our advisory board members for giving various insights. Dr. Madhulumba ma'am, Dr. Usha Goenka ma'am, Dr. Neela Mishra ma'am, Dr. Sangeeta Saraswat ma'am, and Dr. Renu Pranjan ma'am. I appreciate and thank our young and dynamic MOC, Dr. Divya Tripathi, for a flawless conduction of the webinar. Last but not the least, special thanks to all our audience and the academic partner, Walter Bushner, Dr. Vishal, Dr. Yogendra, and others for the technical support. Thank you and good night.
Thank you so much, ma'am.
Thank you so much, everyone.
Thank you. Bye. Good night.
Last but not the least, Dr. Walter Bushner for conducting this beautiful
Yes,
program.
definitely. I said
Thank you,
that.
Dr. Shobna.
We are
you're
extremely
always,
grateful to
you're always
Kanpur Menopause
amazing
Society.
and
In very short time they have arranged, ma'am. We actually
Good night, madam. Good night. Good night.
Good night.
Madam, you are in hall, na?
Yeah.
Thank you so much, ma'am.
Dr. Walter Bushner.
Thank you so much, ma'am, for giving us this opportunity to participate in this scientific symposium on Menopausal Hormone Society. Thanks to Kanpur Menopausal Society. Thanks to Anju Soni ma'am, Dr. Shobna ma'am for the wonderful talks, and Dr. Garima Gupta, Dr. Divya Tripathi, Dr. Kiran Pandey ma'am for all other panelists for arranging this knowledge dissemination program. We at Walter Bushner ma'am would love to conduct such programs in the future as well. Thank you so much, ma'am, for giving us this opportunity.
Thank you. Just a second. From this platform, I'd like to invite everybody to Jabalpur for the West Zone Yuva Foxy. All of you are most welcome.
Sure, ma'am.
All of you are welcome to Calicut for IMSCON 2020.
Definitely,
Yes,
ma'am.
Definitely, ma'am. Definitely.
Definitely.
So then Dr. Shobna, I think I will also have to invite everybody for Wise Zone conference to Jaipur on 24th and 25th of September.
पहले बोलने का था, भूल गया, अभी खाली 24 people are left.
जो पहले बोलेगा उसके में आएंगे.
भूल जाता है.
No, but we have even kept a one-day excursion tour, half-day excursion tour, and a special dinner at Chokirani. So everybody is invited to, and it's the best weather for Jaipur, no heat and pleasant weather. So Jaipur would be heaven at that time. So all of you are welcome.
Thank you. Good
Definitely.
night, ma'am.
Thank you. Thank you so much. Good night.
Thank you, Anju. Definitely, thank you. We'll be there. We will be there. You will be there from there. Kiran, you have to come.
Yeah,
Ambuja madam, Shobna madam, special
See
regards
you all
to
in
you.
Calicut.
Shobha madam.
And
Yeah.
all the best, Dr. Pragya.
Thank you. Thank you so much. Thank you so much.
All the
Okay,
best,
bye.
Dr. Pragya ma'am and Anju Soni ma'am.
Thank you.
Okay,
Thank
bye
you.
everybody.
Bye.
Bye.
Bye. Bye.
Bye, ma'am.
Bye.
Divya ma'am, I'm ending the meeting for all.
हाँ.
Yeah.
Okay.
Bye.
Okay.